I'm Andy Rosenkrantz, the editor-in-chief of AJR, and I'm here today with Dr. Bettina Siewert, Associate Professor of Radiology and Vice Chair for Quality and Safety at Beth Israel Deaconess Medical Center. And she'll be discussing with us her recent AJR article exploring moral distress in radiology. Dr. Siewert, thanks so much for joining us.
Thank you very much for the invitation. It's a pleasure to be here.
To start us off, what is moral distress?
So moral distress is a feeling that physicians encounter when they know the right thing to do for a patient, but for several reasons, institutional constraints mostly, they are impossible to pursue that action.
And how is this different from burnout?
Yeah, causes of burnout are different. Oftentimes it's related to too many administrative tasks, lack of respect from administrators or staff, long working hours is very important in the cause of burnout, and lack of control over the work environment. But for moral distress, what is at the core is the feeling that I am doing something that is ethically wrong.
Okay, let's now turn to your study. Who did you survey in this work?
Yeah, so the survey was sent to a listserv of the RSNA Quality Committee. So these are people who either participate in the committee or who have expressed an interest in quality assurance work, and therefore join the RSNA informational group on quality initiatives. Those were about 425 radiologists on that email list that participated in the survey.
And what kind of response did you get?
So we had 105 people responding. We needed to exclude about 13 surveys because they were incomplete and did not contain enough information. So 93 surveys were included in our study.
The core of the survey was a series of questions about certain scenarios that may be associated with moral distress. Can you explain these questions and what they showed?
Sure. So we had 16 questions that have been used in other clinical scenarios. So these the surveys come out of work that has been done with anesthesia, intensive care physicians, emergency room physicians, and they look at different clinical scenarios. So for example, if physicians are asked to perform procedures that are considered not safe, or if their workload exceeds their capacity, so that the physician performing the procedure doesn't think it's safe any longer. If there are communication issues between the clinical team that is considered morally concerning, or if the patient is not asked to give appropriate informed consent, and communication with administrators, if there's not enough support for the clinical work that needs to be done, that is also experienced as morally distressing.
And how much moral distress were the radiologists experiencing for these scenarios?
Yeah, so it was surprising to see that about 98% of radiologists had perceived some level of moral distress. And it varied very much by the scenario that they were considering.
You also explored associations of distress with a range of radiologist characteristics. What did that find?
So we did not find any difference in terms of demographics, either age or gender of the radiologists, the different subspecialties that radiologists were working in, as well as the practice type, whether it was an academic or a private practice or a hybrid practice. Also, there was no correlation with the practice setting. So if somebody was working entirely on site versus people who were working entirely remotely or again in a hybrid setting, there was no difference that we found in the presence of moral distress in those work environments.
You also asked about radiologists leaving their clinical positions. What did that question turn up?
So we found that about 18% of respondents had left a position because of moral distress, and that 28% of radiologists had considered leaving their position because of it, which is a large number, almost about 50%. The experience of moral distress was so impactful that people had considered leaving a job or had actually left a job.
And then you looked at the association of moral distress with the COVID-19 pandemic. What did that find?
Yeah, so before the COVID pandemic, moral distress was already present, but over the course of the pandemic, it increased that, so that about 50% of radiologists were after and during the COVID pandemic were in the high to very high category of experiencing moral distress.
Let me ask you now about this next portion of the analysis, where you categorize scenarios by root causes to see the kinds of causes and patterns in scenarios most associated with moral distress. What did that reveal?
So the three most common causes of moral distress were that radiologists were asked to read a higher volume of cases that they considered safe to do, that they did not experience support from administrators for clinical issues in patient care, and then for academic radiologists that due to the high workload, they felt they were unable to teach residents because of lack of time.
And then finally, you asked about countermeasures to moral distress. What did the respondents say regarding that question?
So the most important countermeasure that radiologists suggested was education of leadership on the causes of moral distress. And in particularly in one of the free text entries, we saw that there was a perception that leadership was disconnected from the experience of moral distress and the causes for moral distress on the front lines, and that education would be very important.
What is your group planning to do next in your research into this area?
Yeah, we're looking to expand the survey to include a variety of institutions across the country, with the thought that possibly the causes of moral distress may be different in each department, so that if in fact that is the case, it would probably be helpful for every department to look at moral distress in their environment and then to define countermeasures that specifically address the issues that are experienced locally.
Any key limitations to mention?
Yeah, so unfortunately, the causes of moral distress are systems causes that require interventions at a higher level. So, for example, the high workloads in radiology that are experienced across the country would need to be addressed by leadership. One of the issues of high workload that again was mentioned in the free text entries are ordering of inappropriate studies. And it seems that as a specialty, we have to really address it with our clinical colleagues. We have to get back to radiology as a consult specialty. We have a lot to contribute to patient care. Our expertise, we have to be able to bring that to bear and to really contribute that to patient care.
Any final takeaway for our listeners?
Yeah, in terms of I think in terms of the individual, taking care of moral distress, it's really important to connect in this time to the purpose that we are experiencing in our work and to rediscover that. And then hopefully try with the rediscovery of that purpose, try to improve the local environment as much as we can through connection with our referring clinicians. One of the countermeasures that was also mentioned was increased interspecialty dialogue. So to seek more dialogue with our referring physicians and to bring our contribution to patient care to the forefront.
Dr. Siewert, I really appreciate your coming here and discussing your work with us.
Thank you so much. It was a pleasure to talk to you.